I'm your pinch hitter, so I'm sorry I'm late, but I had planned this. I wouldn't plan it ever for Wednesday at 5. So, I want to talk to you for about a half an hour or whatever time you want me to speak about the kind of patients we see in special patients clinic. Is anybody familiar with special patients clinic? Anybody ever been through here? Through there? Yeah?
I've been through there, but
yeah. Oh my God, I hope you have, well, I stayed up till 1:30 doing this. You know how you start looking about graphics and changing things? Yeah, so I'm coffee fueled this afternoon for you. We treat people who have such significant need for treatment modifications that they should be seen in a sheltered clinic. What that means is it can range from Doña Emilia, who's 106, to a 21-year-old patient who got timed out of Children's Hospital of LA and who has intellectual disability and a bunch of other stuff. And we're going to shelter her or him there in our clinic, maybe give them some sedation in our clinic. This is from the Hollenbeck sniff. I just came from there in East LA, Boyle Heights. And this is one of our patients that we're seeing, treating in wheelchair. Okay, there's a question on this later. Okay, so just by way of background, USC paroled me for good behavior in 1978 before any of you were born. That's true, any of you, because you're all like my kid's age. And then I practiced dentistry, general dentistry in West LA for 25 years. And then I sold my practice and decided to come back and volunteer teach. I'd really burned out of, I don't like business, so that was bad to be in solo private practice and in business. But I loved dentistry. We had a lot of fun in dentistry. So I came back here to volunteer to teach pediatric dentistry. So of course it's only natural that within about 2 years I'm full-time in the geriatrics clinic, you know, and have been there very happily ever since. We actually had this really significant event last night. It's the 30th anniversary of Special Patients Clinic, and the founder of it, Dr. Roseanne Mulligan, along with her husband, Dr. Glenn Clark, who runs, is a world-renowned guy in oral facial pain and oral medicine. They did a gift to the school to endow in perpetuity that clinic. Well, I don't know how in perpetuity works with the school, but you know, for a long time. And it's now going to be called the Roseanne Mulligan Special Patients Clinic, as it should indeed be. So it's a big deal. All right, so here's an overview of kind of what I'm going to be talking about today. So, things happen. Anybody know who this is? Were you too young for the first iteration of the Superman movie with Christopher Reeve? This guy was like a hero. Man of Steel. Total man of steel. This guy, you know, had a 18-inch neck all muscle and stuff. And that worked fine till the day the horse refused the 2-foot jump, and he went over the jump. Horse didn't. Over the jump, planted his head and his body went like that, breaking it at C1. And that was Christopher Reeve. And he became a major spokesperson for disability the same way old Michael Keaton, not Michael Keaton, what's his name? Same way, Back to the Future. Michael J. Fox, yeah, Michael J. Fox became a spokesperson for Parkinson's disease. And you never know. I love Special Patients Clinic because you get to expose people who have never seen this kind of thing to people who've had some real hard stuff done in their lives. And you get to see the dental students get to know them as people and individuals. So it's really exciting to me. And they also get to treat them as clinicians, but they get to see them as people. And if you've ever had anyone in your family in a wheelchair, or, you know, you want to try a nice experiment, you know, put an eye patch on, have someone plunk you in a wheelchair and wheel you around and see how invisible you can become. It's amazing. But they're us. So when someone comes to Special Patients Clinic, we need to figure out what makes them so special. She's 85 now. She's amazing. But special needs, medically complex. It's like, where do the people with double lung transplants go to get their dental work? If they're too healthy for a hospital, they come to us. And they can come to dentists in the community who aren't too freaked out to treat them. Frail geriatric, sedation, oral medicine. And if people are in a wheelchair, you don't want 15 of them up on second floor when the big one hits. So to some extent, you don't want a huge population of semi-mobile people up on second floor in this dental school that need to be helped down. 300-pound person in a wheelchair who needs to be helped down the stairs when everyone's cascading down the stairs. It can be a real problem. So what we like to do is keep them in our clinic. Oh, and how old is old? If you're 80, you're kind of young. So I mean 85, something like that. But we have an 80-year-old who's really great. He just likes to be there because he likes to get coffee. So what are the treatment modifications we needed? Treatment modification means, of course, what do you do differently? By the way, I'm pretty informal. You got a question, raise your hand. Okay. Okay, so for example, what she needs is, I think, even though she's really chill and she runs around all over the place, we have to make sure she gets in and out of that chair safely without falling. Because an 85-year-old falling is very different than a 58-year-old falling, and way different than a 28-year-old falling. Things can break. You break a hip, you end up in the hospital, you get a nosocomial infection, you get some really nasty infection from the hospital. You get a deep vein thrombosis from not being able to walk around because you broke your hip. You get pneumonia. You get, you shouldn't get bed sores in a good hospital, but there's all kinds of stuff that can happen when you're lying there like this in a hospital. So safety is one of our first issues. And we also have other modifications that we need to do for someone who's 85. But here's who you might find. This is an autistic patient. Did anybody here ever see the movie Temple Grandin? Okay, who likes movies? Okay, who has Netflix? Who has a friend who has Netflix? Come on, streaming Netflix. Everybody? Yeah, if not, you can come to me. Okay, there's a great movie, true story about a woman named Temple Grandin, who's autistic, who grew up to be a cow expert. She kind of sees the world from a cow's point of view, in the sense that she works with slaughterhouses. I mean, yeah, the vegetarians and the vegans here can just go, ah! But she, one of the things she did is she made a machine that kind of squeezed her, and it calmed her down. Kind of like swaddling a baby, that kind of compression stuff. And what we're doing here is we're draping a whole lot of stuff on this autistic patient to kind of calm her down. We do a lot wrong. We shouldn't have big bright lights or anything. You can create a perfect sensory environment for autistic patients, and that would be optimal. We have the cast of Glee. No, we don't. We just have. We might have people like Becky from Glee in our clinic. She's got Down syndrome, and we may have her in our clinic, or she may go upstairs. But often, at least the Down patients who have behavioral issues and cardiological issues. And that is my friend, the late, great Zeddy Khan, who had Lou Gehrig's ALS, and his implant crown came off. So he went to his dentist up in Seattle, and there he is. They had to prop his head up because the only thing he could do at this point is wiggle one eyebrow and blink one eye. So that's who you treat. Do they deserve dentistry? Absolutely. What's cool about USC, plug for USC, is that we have this dedicated, incredible clinic. So more patients, you might see Lee. She plays piano. She's 101. And she's got some significant forgetfulness, but sometimes you just see her at a table getting ready to eat dinner, and she's like this. That's Randy. And this is Peter Wolf of Service Dog. And we just lost John, who was the youngest demented patient in very early dementia. And we just lost him 2 weeks ago. In home. Here's some medical conditions you might see in a special patient's clinic. Now, mind you, you might see any and all of these in your own practice. But in terms of training, you guys are pre-dent. So it kind of goes pre-dent, dental school, dentistry, and pre-dent does not equal dental school, and dental school does not equal, like dentistry and pre-dent does not equal dentistry. It's not. A, B, and D. Okay. You'll definitely see these conditions everywhere. This woman's on an anticoagulant or an antiplatelet, I forget which. Why there? Because she doesn't see the table when she bumps into it. And one of the treatment modifications you can do for your home or your clinic or your anywhere you work is to have this beautiful open space modern office with rounded tables. If you've ever seen a baby-proofed house, a toddler-proofed house, you don't see a lot of sharp angles. Same thing with this 95-year-old nurse. She didn't see it. She went into it and she got some bleeding. Anybody know what's going on with this guy? Take a guess. This girlish figure, what do you think? That is wasting of eggs. You can see a lot of AIDS patients. And you might think that that's that guy's normal color up there. It's not. What can turn somebody whose skin should look this color? This color.
Jaundice.
No.
Smoking.
It's a good, jaundice can do it, but I should say no. Yes, it can, but that's not why for this guy. This beautiful gold and brown color of end-stage renal disease where your kidneys don't work and you're very toxic. But you're right, jaundice can do it too. So you might see all of these. You might see a really bad case of rheumatoid arthritis, and I put this up here as an example of how your systemic conditions can certainly impact the dentistry you get. So I mean, look at this woman, try to put her denture in her mouth. Like, she does it. She does it. But one of the things we did is we took some old putty, or you could take an old tennis ball or a soup can if you wanted to, and you put your toothbrush through it, and now she's got a big handle to it. If you ever want to know, this is participatory here. It's bad always to sit in the front row, you know that. Okay, so, all right, now, grip, okay, now, give me one finger. Okay, so if I grip this like this, and I have 2 fingers, and I have 3 fingers, which was the strongest? Right. So if you have a patient with significant weakness and debility, you can hold out successive fingers and see where their grip's strongest at, and then you make the handle to fit that. So it's kind of cool. You learn a lot of very practical, interesting stuff. Or maybe not interesting, but practical stuff. Ah, okay. Okay, what is that? Is that caries? Anybody know? Besides a hell of a lot of it. Do you know? Those are carious lesions. Those are the symptoms of a bacterial disease of lifestyle called caries. And those holes are called cavities. But these are the symptoms of a disease. Actually, as a matter of fact, that is the most common disease in dental school, probably, is the disease of caries. And people are always confusing the two. But if you guys want to be 21st century practitioners, you will treat biochemically and nutritionally and whatever, treat the disease of caries to minimize the lesions that you have and to remineralize the lesions that are there so that you're not like most of the dentists. Dentists currently get paid to fix symptoms of a disease. They do not get paid to diagnose and manage this disease. And it's a bidirectional disease. You can get total demineralization to the point where so many minerals are taken out of the tooth that you get a cavity, a hole, or it can go the other way and you can remineralize previously decayed tooth surface. Of course, if there's a hole already, it'll still be a hole. But 21st century dentistry, you try to minimally invade the tooth because there's nothing stronger than the least cut tooth or even one that doesn't even need a filling. And you, first and foremost, you manage the disease. Because if you put a filling into a patient where you haven't analyzed all the things that go into what caused it, then it's going to keep happening. Putting a filling into that mouth, putting crowns in or whatever you want and all of that disease will not stop the disease, and it will continue. And it'll wreck all of what you put in. Kind of like trying to fix a second floor window in a burning building. Always good to put out the fire first and make sure the arsonists don't get back in. This just happens to be the most brilliant grid you'll ever see for patient management. This is geriatric dental care, but it could be any dental care. And what you do is you kind of go this way. That was some special patients. You look at all their medical conditions, because frankly, like my friend Carmen is going to visit a friend of hers who just had a stroke and is in Rancho right now. And you know you're never going to get to the dental part simply because he's going to be stuck here. He's too darn sick. So you look at the systemic conditions and medications. It gives you a whole grid. And you can actually take any given patient, any given person, and superimpose it right on that. And you can answer all these questions. Then you go over here to psychosocial. Okay, medical. But who's giving consent? Let's say they're demented. Or they're delirious or whatever, and they cannot give their own consent because they can't appreciate what the issues are. Okay? You've got to have somebody give informed consent. They have to have the cognition to reckon and recognize and reason what the issues are. You have to have the support system. Because let's say someone's healthy and can consent, but they can't get to you. Or they can't, you just need support system for all this. You need to have all that done. Mental status. You don't want someone who's psychiatrically ill, necessarily. It might blow up your dental. And then behavioral. Can they cooperate? Do they need sedation? See? Home care capabilities. You can do the work. They can get there. They can pay for it. They're going to let it go to smash because they do not have the capability or the commitment or anything to keep it up. Because the fight against the disease it carries is never ending. Every meal. Adherence support system. And then we finally get over here to dental. Most dentists just go right there. Exam, influence of systemic conditions. For example, let's take a very common one, diabetes. Diabetes, your gums don't heal so hot. If you have very high blood sugar, very out of control, there's a number. Anybody know what the lab thing is, the lab test is that they use to bust your blood glucose for every 3 months? It's kind of like the ultimate diabetes drug test. There's a test that everyone who has diabetes gets every 3 months that tells you how in control your blood sugar has been for 3 months. So, it's called hemoglobin A1C. And if you've got a hemoglobin A1C of 13, you ain't doing dental work on that person necessarily, or at least you're going to pre-med because they're not in such great condition to do treatment options, delivery of care. But this treatment options is informed by all of this. What are my treatment options today for one of my patients who's edentulous and who's 93 and who's demented as all get and who has tardive dyskinesia, which means it's a pharmacologically induced, never gonna go away involuntary movement of her tongue. Her treatment option, no dentures. She couldn't know how to use them if I made them, and she couldn't keep them in her mouth if I did. So sometimes, if you really analyze all this stuff well, it'll really give you what someone's options realistically that will succeed. Okay, so there's our major disease. We're about to this guy has a partial, and that's where the partial fits institute, and that's the disease, the symptom of the disease it carries. So there's something called the caries balance. I'm sorry, I tried to get rid of this heinous color, and I couldn't. By the way, you know what happened to this person? A lot of minerals were taken out, but something was stuck onto this tooth. Does anybody know what that is? Look at the shape. What was on that tooth? Orthodontic bracket. This person had braces and never brushed. See? Everything in minerals taken out. The tooth was white, but not where that orthodontic braces bracket was stuck on, right? Orthodontists, yeah, they don't like this. Disease indicators. White spot lesions. Enamel turns white. Exposed roots don't change color. They lose density and hardness and stuff. Active enamel lesions. This is a whole bunch of lectures. Here's the risk factor. Do you have germs that produce acid in your mouth? Everyone has germs in their mouth. Everyone's going to have plaque, that adhered layer of bacteria. But if they don't produce acid, they can't take out minerals because a healthy biofilm, a healthy bacterial plaque, doesn't put out acid. No acid, no minerals taken out, no holes. Okay? One of the biggest risk factors that my patients all have is inadequate saliva. And it tends to make the saliva very acid, low pH. And saliva usually buffers, provides remineralizers. I dare you to eat any kind of like shredded wheat when you're dry mouth. Ever tried it? grape nuts, stuff like that, you know. It lubricates teeth. It allows you to eat comfortably. It's antibacterial, it's antifungal. It maintains the salivary pellicle on the tooth. It's critical for caries, disease management. No saliva, all bets are off. You're extreme high risk for the disease of caries. What you put in your mouth, refined carbohydrate snacks, and inadequate fluoride. You can give people fluoride till the cows come home. If they've got a bad enough diet and poor oral hygiene, it's like not going to happen. Okay, and these are some of the protective factors. So this is one blueprint for how to manage the disease of caries, our number one disease for all our patients. If you're going to be a periodontist, yeah, this is what concerns you. Okay. We get to be creative in special patients. Our patients tend to be all dry, no saliva. Don't brush, maybe because they're feeling too sick or too depressed or feel, we have an issue with that. So this patient had decay everywhere at their root. Why? Because roots decay twice as fast as this white enamel stuff and at a much higher pH. You can have a much less acid saliva, oral saliva, and it'll start taking minerals out of roots way before enamel. So what we do is we put a bioactive filling in there that actually sucks up fluoride and exchanges strontium and fluoride with the layer underneath. So we go and spackle that on all the holes. It's very helpful. And then we go, and when they've controlled the disease of caries, then we can go back and do definitive work. What happened here, guys? You know what you're looking at here? What is that? Oh, come on. Everybody wake up and tell me, what do you think that is? Are these real teeth? No. Your real teeth, like when you lose a piece off your real tooth, you have metal exposed? No. What are we suspicious of for what this is? Oh, come on. Someone take a guess. Oh, is everyone really going to be shy? Okay. Bridge, you know. This tooth and this tooth, and there's probably more of the bridge over here. This is called the bridge abutment. This is a bridge abutment. They ground this tooth down. This is a fake one, this is a fake one. I don't know what the hell's over here, something better be. But this person, something happened and the porcelain flexed. And a porcelain bridge or a porcelain crown, old school, is baked at 3,000 degrees onto metal. Well, we could put the patient's head in a 3,000 degree oven and bake that thing back on, but it's a little tough on your patients. I don't like that very much. So what we do is we put a masker, we sandblast, we put a masker on, we put a molecule on that sticks. There's a lot of chemistry in dentistry. It's really cool. There are chem majors out there, aren't there? Admit it. Oh, they're all sliding down in their seats. Be proud, chem majors. I wasn't one. I got really good chemistry. So there you go. We're fixing it until it looks like this. That's a lot better than replacing a bridge, especially if someone's like 85 years old and doesn't have either the money or the patience or even more important, the health to remake something this big. So it's cool. We do a lot of that stuff. Here are students in special patients clinic. We are lucky because we have private rooms with doors that close so that, people have a little bit of privacy. We have dental assistants, x-rays, and patients who are stirring up alginate to take impression of, mold. This is Dr. Suarez. She is the HEFA of our office. She's the section head, the head of special patients clinic, oral medicine specialist. And this is Ryan Blue, when he was a dental student. And this guy made good. He didn't end up on the IB team, which is a very select team, because they didn't know about him. But he really wanted to be a dental anesthesiologist. And darn if the guy didn't go to New York, become a dental anesthesiologist. And now if you see Ryan, he's there putting people to sleep for us on Thursdays and Mondays, I think. Really great. We got him as an anesthesiologist. Intra-professionalism means all the oral health professionals working together. And that can mean your dental assistant or your certified nursing assistant in the nursing home who's brushing your patient's teeth, and the general dentist and the periodontist and the implantologist and the endodontist. See the microscope? Very cool microscope, 60-time magnified. Or oral surgery. Notice the nasty stuff over here. Yes, forceps. So these are some of the various things. And working in the dental school is like a dream for me because you need a consult, you just call one of your friends. Hey, Endo, come on over here and see if this tooth is dead. The nerve is dead in the tooth. Would you guys like me to define these terms? Are you guys familiar with these terms? Yeah? Everybody knows what I'm talking about? Did everybody do dental explorers? Yeah, I know you did because you're familiar. But oral medicine, most dentists don't really even know about. It's a specialty, a 2-year specialty. And these guys train in systemic diseases of the orofacial complex. So if there's some kind of lesion and you don't know what it is, it needs a biopsy, the pathologist might look at it under the microscope, but oral medicine might analyze medicines or whatever and give you a good idea of what's going on there. They're very critical. These are the guys, when someone's under treatment for breast cancer, these are the guys who I take that patient to and say, like Dr. Suarez, and I say, hey, we're going to output a consult, the oncologist, to see what's going on in terms of treatment timing, because if all the white blood cells and neutrophils are tanked really low, we ain't going to be doing anything that lets a lot of bacteria into their bloodstream, like cleaning teeth or something. So we work together. Oral medicine people are really good at treating people with some very horrendous systemic diseases that impact oral health care and helping you with treatment modifications and timing. We need lots of specialists. Perio, orthodontist. He moved to Virginia, but we still love him. Prosthodontist, oral medicine, and bilingual. It's not fair. Oh, they're all bilingual but me. Anyway, interprofessionalism is what I got a chance to do today, which is collaborating with others. And medical doctor, occupational therapist, speech therapist, physical therapist, registered dietitian, shrinkiatrist, certified nursing assistant, registered nursing assistant. And this is my friend Helen, who had, you might notice that she looks a little funny. It's because she had stage 4 throat cancer. And the doctor resected her here. And when across the midline, he got a little bit, we'll do another surgery. And she said, after she got done, this one's like, I don't have enough time left on earth to be doing your surgeries, thank you very much, I'm done. So we threw her in the skilled nursing facility. And when I met her, when the speech therapist took her to dental and said, can you help this woman? Helen was saying things like, and a guy named, let's see, do I have it in the slides? Well, if I do, you'll know what I'm talking about. A maxillofacial prosthodontist went and made an obturator that went in there and closes off, and she would say, what she just had said was, it's really hard to talk, and no one could understand what I'm saying. Then it sounded like this when she talked. Just that clear. She went back to doing bridge, died in twice the time that we thought she lived. She lived twice as long and snuck out and did bridge and all kinds of stuff. I won't tell you that. That, I don't know if you can see it, it's a really crappy picture from here. That's a bitten tongue. Let's see if we can do this. Oh, sorry. The MD called me in the skilled nursing facility, and dentists who are in skilled nursing facilities were part of the oral health service, just like we are in hospitals. And they called me in and said, her mouth is bleeding, figure out why. Now, this patient was, of course, demented and, totally wild. But we managed to get a hold of her and open up her mouth, and we saw a lesion this big on her tongue. She'd bitten her tongue and was bleeding. So it was nice at least to know what it was. And this is a patient being held up by physical therapy. He's learning how to be a little bit more steady. And of these other professionals, you're going to work a lot with the MDs for consult. You're going to work a lot with the nursing profession, including to get lab values and other things. And speech therapy especially, because Cece Young, who brought her to us, when you're working with a speech therapist in the nursing home, you're all about, can they swallow without putting all their food right down their trachea? It's all about something called dysphagia, difficulty swallowing. Now, part 1 is chewing food. Part two is having the tongue like toss it back and forth between the teeth and then get it to the back of the throat. And then there's the oropharyngeal phase where you're swallowing it and making sure it goes down the trachea. And then like getting it to the stomach. The worst part of it is usually that middle one. But occasionally we get consults because people aren't chewing their food properly because of their dentition. But there you go. So, oral medicine. Yeast infection of the tongue. Yeast infection of the side of the mouth. Pancreatitis. You're going to be talking to probably, well, specialists. You're going to be talking to a periodontist and an implantologist. This is our friend Jimmy Tom. He's head of anesthesia at USC. He's really cool. Brian works for him now. And in special patients clinic, if you're unable to obtain cooperation, either from the patient willingly or if they're unable to like stop, they've got cerebral palsy and they're just like moving all the time and it's not going to happen, you might want to give them sedation so that you can deliver appropriate dentistry under sedation when you can control the situation and you can get to them. For demented patients who are significantly older, you want light IV sedation. But this is general anesthesia that they're running there. And we have one good operating room suite in the back of USC Dental School. And this is Helen when he was making it. And this is how far back, this is your normal retainer, right? That's how much stuff she lost to be able to close the back of that throat so that when she put this, she could take it out and then she'd put it in and she'd say, I can't be understood. And we had a wonderful maxillofacial prosthodontist who came down. Now, how many modifications over here? That's Dr. This is our promotora, Carmen Molina. She's incredible. And Hollenbeck. This is Dr. Viola Esperis, who closes her office and drives 2 hours each way to come and volunteer for USC at this building. And for those of you who lose faith, having wacko kind of, really wacky kind of degrees, undergrad, cinema major. Okay, so, very dramatic, very emotional. So what do you see? What's Carmen doing? Holding her head still. Anybody ever seen one of these things? That's called an open wide extraoral bite block. It kind of goes in there so that she's going to keep her mouth open and not close it on her fingers or on instruments or anything like that. Okay? You guys ever see those? That's a light. Actually, matter of fact, that's a light that was designed by one of our students who's no longer doing dentistry. Not doing dentistry. He's selling the world lights. Scopes, lights. She's being treated in her wheelchair. Because really she can't transfer out of it well to a dental chair. There'd be no reason. So we're doing her stuff. I think we're probably doing a cleaning or something like that. These are some of the modifications she needs. So hospital dentistry, what might you see? This guy has what's called DRESS syndrome. It's a really bad systemic reaction. That's prednisone phase you're looking at. These are the kind of things that a hospital might do. If you guys haven't met Dr. Richard Green, who's one of the co-directors of County USC, he is just a peach. You guys should meet him sometime. Some more things that they do, advertisements. And there's where he lives. He's got a salmon pink wall. You can see it when the lights are on from outside. And general practice residencies, geriatrics, all this stuff. There's all kinds of things besides the specialties that can help you with special care dentistry, with medically complex or geriatrics, whatever. Right now, there is no specialty for anesthesiology. Jimmy, who kills people on a regular basis and brings them back to life in general anesthesia, jokes that he's a general dentist just like me. Because there's no specialty for them. There should be. But, you know, the specialties, pedo, endo, pros, stuff like that. There's lots of postdoctoral training possible. And here are some of your careers for special patients and in general for dentistry. Dentistry is really cool because you could do a 25-year mid-year shift like I did, career shift like I did. First 25 were private practice, GP. Second 10 years, the next 10 years we're teaching. Our teachers. Okay. There are organizations. If no matter what you want, you're interested in dentistry, I guarantee you there's a Yeah, okay. Hitting the road. Mobile clinic, mobile clinic. Jim Arbor, we're growing. Just do it. Bye. Anybody wants any more information, please? Sorry I was late. You are so welcome. It's nothing like being a pinch hitter. Okay. I apologize for anybody who's
Josh.
You guys, please grab food on your way up. There's a lot of things left.